Our next session today really looks at building back better surveillance alert response systems. And we've seen through previous pandemics and the last few sessions that certain lower to middle income countries with strong surveillance systems were able to perform better than some advanced countries. The pandemic also brought out the role of digital and molecular technologies in undertaking essential health system functions. Please join me to welcome Dr. Shrikant Thematic, Technical Head for Public Health and Capacity Building at Access Health, who will make a short presentation before our panel discussion. Shrikant, please.
Thank you, Tim. Yeah, so I request all the audience to kindly settle down, please. Yeah, so welcome again to this eminent conclave and the discussion, enriching discussions what we are going to have today and tomorrow, of course. My role for this particular session is to run you all through what exactly we have done in last couple of years on disease surveillance as one of the thematic areas of GLC4HSR. So I will just try to quickly run it through. I asked my moderator to give me around 5 to 7 minutes, so I will just would not like to take more than that. Yeah, so I would like to divide the work till what we have done till now into these three pieces. First piece is obviously what we have started is systematic review on surveillance systems assessment approaches. The second piece, what we have conducted with the help of obviously Tata Institute of Genetics Society Bangalore, the conclave on building back better surveillance system. And third piece is what we are currently trying to do or trying to develop is surveillance alert and response systems blueprint. So I'll just quickly run you through what we have done in systematic review for surveillance systems assessment approaches. So in systematic review, we have found we have followed the Prisma technique, obviously, as per the guidelines. And then we have found very interesting results. We have found around 114 articles, which are talking about various approaches or various publications which different countries are using for obviously assessing the surveillance systems. And most interestingly, we have found that around 30% of those articles have published post-COVID. So it has included various newer surveillance technologies or methods which currently countries are following. And obviously before that, we had various techniques around wastewater surveillance, which are again we are going to discuss in this panel discussion, and digital surveillance. But suddenly post-COVID, we have found that various newer technologies coming up, countries accepting those technologies, and again assessing where they are standing as well. So these are the list of few indicators. We have found very interesting indicators which are more frequently used. Some of the indicators which are used specifically for that particular surveillance system. For example, we have divided these indicators into three systems here: public health surveillance, health information systems, and animal health surveillance. So obviously this is again the work which are soon we are going to publish, and maybe it will be disseminated in a month's time. So these are the list of few of the checklist, guidelines, frameworks, which we found that most frequently used. Obviously, two major organizations, that is CDC, Center for Disease Control and Prevention, and World Health Organization, which are have been driving these assessments with different tools, frameworks. There are different even frameworks for the specific surveillance systems, like for example, injury surveillance. But yeah, we are just trying to get the gist of those indicators and different frameworks together with our systematic review. Then next is this is the group. We have gathered some of the expert people working in the field of surveillance. We have our own team working dedicatedly on this particular systematic review. We have got representatives from ICMR, we got representative from ex-CDC and Red Cross Canada. So quite a good experts involved during this discussions and work of systematic review. So obviously it led us to this conclave where we wanted to discuss or explore more of this newer areas or newer surveillance systems. Like for example, what we have discussed during this conclave was around wastewater surveillance and other applications around molecular technologies, data-driven surveillance, and digital technologies. Again, we had very good eminent panelists there as well. The proceedings, I guess, we have already shared with all the invitees for this conclave as well, and it's available on our website for reference. So these are few topics which we have developed during the conclave, which led us to the next part, or guided us to the next part or the work which we are planning to do, or already started the work on this particular piece of surveillance alert and response systems blueprint, where we are trying to maybe assess what are the current guidelines or current documentations available. So we got a very interesting document of Niti Aayog, which talks about India's vision 2035 for public health surveillance, which was released pre-COVID. But yeah, it was well drafted and documented piece, which we are trying to maybe give inputs from various expert group and maybe take it to the next level with the learnings from the pandemic, COVID-19 pandemic. There are a few more documents like from Canada, which matches our federated systems for public health surveillance. There is again like documents from African Union event-based surveillance, and there are good documents on new age surveillance as well. So this is what we are trying to do now, and that's where this panel discussion was drafted, to maybe bring on board like from experts from various systems of surveillance. So yeah, I guess that's it from my end, to just to give you a brief about what we have done till now, and how we are going to go to the next step of developing this particular document of blueprint. And hopefully this particular panel discussion will again guide us for taking this step forward and developing the blueprint for the Building Back Better surveillance system. That's it from my end. Thank you very much. I would like to maybe hand it over to Professor Sten now. Over to you.
Very good. That was an excellent introduction. We have a term from WHO and other groups: pandemic prevention, preparedness, and response. And this, I think, also dovetails with the term we're using here, surveillance alert response system. We have a distinguished group of panelists. Just by self-introduction, I'm a pediatrician and infectious disease epidemiologist. I work at Yale University as a professor and dean emeritus, and I'm the president of the Global Virus Network. And our first speaker is going to be Judith Wong. Now, she is one of the directors of the Environmental Health Institute in the National Environmental Agency here in Singapore. And Dr. Wong directs microbiology and molecular epidemiology division. And since she's working on environmental monitoring, biosurveillance, and even vector-borne diseases, she's a great person to kick off our session. She has a brief formal presentation, and we'll invite her.
Thank you, Prof. Right, okay. Thank you very much for having me here. And maybe just to our overseas guests, I just want to welcome you to Singapore. And I'm from the Environment Agency in Singapore, and today I will be sharing a bit of some use cases that we have implemented environmental surveillance and how that has helped like public health, risk assessment, and responses. And hopefully that will give us an appreciation of like how we can use surveillance systems in addition to the traditional case, for example, hospital bed surveillance systems, to really complement and enhance public health responses. So as for our overseas guests, as you've come to Singapore and touched down, you might realize that, coming into Singapore, we are a very urbanized city, but we are also interspaced with many different natural environments. There are parks just next to our community spaces and so on. So many of the work that we do in our agency is really understanding how this continuum of natural and built environments come together. And specifically in the area of environmental public health, we often ask ourselves whether there are harmful microbes in the environment and how do we mitigate the risk of exposure. I will not go into full details, but just to give a taster of the work and how that translates into policy and action. I will pull out some of these examples in terms of antimicrobial resistance and, for example, our response to COVID-19. But suffice to say, we know that the environment could present as a reservoir, which means that this would be the recipient or the receiving end of many of the, for example, runoffs, as well as like, for example, if we have agricultural activities, some of these would then impact the environment, and that would allow us to use it as a measure of, like, for example, some One Health signals. And for Singapore, because we are highly urbanized, the wastewater system allows us to understand whether or not there are disease prevalence in humans, for example. And of course, in the natural and built environments, when we test the environment, we then also understand whether or not the environment is a route of transmission. So with that, I'll go quickly into some of the examples where we've used environmental surveillance to inform public health response and policy. So for AMR, we know that this is a global health problem, and we often wonder, how does the environment play a role in transmission? So in our agency, we have done surveillance in different natural and built environments. One example is that of coastal water, because in Singapore, we love our beaches. We go like to enjoy the sun and the sun, sand, and sea, and I hope you get a chance to do that as well. And thankfully, when we did sample like the beach waters in Singapore, we did realize that there is no, for example, antimicrobial resistance. So some of these surveillance efforts, although they could be snapshot studies, we try to do it more regularly so that we can inform risk assessment. And if, for example, if there are exceedances in some of these signals, we then can advise the public accordingly. So similarly, we also test AMR in Enterococcus. And also in the built environment space, unlike maybe some countries where there are more agricultural spaces or more natural environments, a lot of us in Singapore live in the built environment where we are exposed to really just indoor air, and we just spend a lot of time in the office. So we also do air surveillance to understand whether or not, for example, our ventilation systems are good enough for like public health. And AMR, surveillance of AMR in the air also allows us to do this like ongoing knowledge of whether or not it's enough. So I'll now shift gears quite quickly to wastewater surveillance, just being mindful of time. So similarly, we also have done wastewater surveillance for antimicrobial resistance. And this was actually done after the COVID-19 situation, because we really didn't step up wastewater surveillance, unlike most countries, until COVID-19 hit. And I'll share a bit more later on about how we stepped up surveillance response arising from COVID. So I'll go quickly now into our wastewater surveillance experience during COVID. So in the early days, when we did not have such a system, we really started in 2020 when we first heard that COVID hit us. And this was from the experience of SARS-CoV-2, where we knew that the 2003 SARS, where we knew that the virus could be shed in wastewater. And that was when we started trials to test for signals in the wastewater. And because we were able to detect signals, we then deployed it at high-risk sites. And this is really an example of how we were able to translate surveillance into policy and action. And it evolved also as the pandemic played out. So for example, in the early days, we really needed to understand and do case tracing because we weren't sure how to control the virus. And back then, the detection of signals prompted, for example, swab operations and facilitated early case identification. Whereas later on, as we evolved in the pandemic, We then used it for monitoring waves of transmission, as well as variant tracking. And of course, right now, as we are living in endemicity, we are using wastewater as a surveillance indicator for other pathogens instead. So this is also an example of how we sort of stepped up surveillance. It is not possible to do it alone as an agency or as a lab. We do need the help of many partners. So we have developed a wastewater surveillance system in Singapore with the help of partners from academia, government, as well as industry. And at the same time, through innovation and technology implementation, we were able to automate the testing and scale it up to more than 5,000 samples per week at the peak of the pandemic. And this was made possible by automating, for example, like these sampling systems as well as laboratory processes. And so with that, I'll share just some examples of how we integrate surveillance systems together. So over here, the graph on the left, on your left, shows the corroboration of clinical cases with the wastewater signal. The wastewater signal is actually the line in black, whereas the case information is the area graph in pink. And here we can see a very good correlation during the time where case testing was active. And right now, as we know, we have already stepped down case testing. The wastewater signals then provides a non-intrusive indicator of the trend of transmission and allows us to monitor signals in a non-intrusive way that is also sustainable and also resource in a way that allows us to use less resources to monitor. And then, of course, we look at variants right now in endemicity as well. And this is a recent data where in 2023, for those who are in Singapore, we may remember that there was a wave of infections, and we were wondering whether or not it would come down. So back then, because case ascertainment has fallen, wastewater surveillance was then used as an indicator to model the reproduction number. So this is an example of how we can use an integrated surveillance system to inform like public health. I will maybe go quickly into the next one, which is how more recently we have also used case, wastewater, and mosquito surveillance to understand Zika transmission in Singapore. Now, why Zika? We know that Zika is actually a very mild disease, but it can cause very severe outcomes in a specific population. So in our experience, we actually combine different existing surveillance systems to sort of look out for Zika. We have an ongoing case surveillance system, which is undertaken by the Ministry of Health, as well as our Environment Agency. And that helped us to understand that there was a re-emergence of Zika in Singapore in 2023. That then prompted us to test the wastewater for Zika because we know that the virus is shed in urine. And we also have an existing system where we monitor the mosquito population in our community, and that is actually for dengue alert. So combining all these signals, we tested the various samples for Zika virus, and we found traces of it in the Kovan Road cluster. And thankfully, when the signals went down, it assured us that there was no further transmission in that cluster. And this was especially important for Singapore because we are not really endemic for Zika and we only experience cases from time to time. So we really want to act on signals when we do see them. And so similarly, we continued the monitoring, leveraging on existing surveillance networks. And this then allowed us to prompt for a more recent transmission area where signals in mosquito and wastewater samples suggested there was an area with likely transmission. And this allowed us to alert the community as well as doctors to look out for symptoms. And this then in turn facilitates early warning. So with that, having seen all these signals in the environment, we want to translate it into policy and action. And in our agency, we have done some of these. For example, when we monitor the beach quality, we do have accompanying advisories and we issue like alerts on our website. Similarly, when we detect signals in air or in like fomites, etc., they then form cleaning advisories as well as, for example, lists of effective disinfectants and mitigation measures. And so with that, I end my sharing. And I hope that this helps us to see how environmental surveillance can complement health surveillance systems. Thank you.
Thank you very much. Excellent. It's very impressive what is achieved here in Singapore. It's the goal that we all seek. Let's stay on the surveillance theme, and Satish Kalikar, who's program manager at Wadhwani AI as in artificial intelligence. And he's going to tackle, he's been working in telemedicine, mHealth, the eICU, virtual care coordination, a whole variety of themes in which AI can contribute. But today he's going to talk about media surveillance using AI.
Good afternoon, all. So after this west-west water surveillance, I will turn towards media surveillance. Next, please. So I'm working as a program manager in Wadhwani AI. This is a Section 8 not-for-profit organization in India, which actually works for incorporating artificial intelligence in government-related softwares and digital health systems. So one of the pages from the books and the guidebooks talking about surveillance, so which talks about the entire surveillance and early warning signals are basically originating from two biggest domains of the surveillance, that is event-based surveillance and indicator-based surveillance, where the media surveillance falls into the event-based surveillance, apart from other things. And each of these two surveillance domains have their pros and cons. Let me contextualize this image from a book to our today's discussion with a metaphor of a roadmap. Like, both of these can be considered as a wheel of a car, and the car can be an overall surveillance system. Event-based surveillance is one wheel, while the indicator-based surveillance is another wheel. Alignment of these two wheels is very important to make disease surveillance more efficient. As today's conference has a broad goal of making the health systems resilient, one of the major milestones to this roadmap is making the surveillance alert response mechanism strengthened and efficient. To do this, it is very important that this car of surveillance should be fast enough and having a better alignment of the wheels. But for any car, there needs to be good brakes and good accelerators. For accelerating the speed of this car of disease surveillance, we have a powerful engine or the tool with us called as artificial intelligence. But every one of you must be aware about the cons of AI also, about the hallucinations by ChatGPT and many things. So when this acceleration can take the car into the wrong direction, there needs to be a brake, and that brake is nothing but the human intelligence. So in today's presentation, I would like to make the use of artificial intelligence for the disease surveillance in India for media. Just to contextualize the Indian surveillance landscape, you'll see India is still having a diverse disease burden, from the ancient diseases like TB up to the new age diseases like Zika, Nipah and all. There's geographical variability. There are challenges in surveillance infrastructure in terms of the human resource for a billion country. And there are emerging threats and global health concerns because India is well connected to many of the countries. And now we will turn towards the media industry. So as you know, India is a home to more than 700 spoken languages. Out of them, almost 70 has script, in which almost thousands of newspapers, dailies are being published. And Telugu, Malayalam, Tamil and all. And the biggest concern is not the multilinguistic thing. Another thing is about lack of standard public health reporting practices among journalism. To create a sensational breaking news, there can be a wrong use of some disease into the media. There is infodemic chance, just like the fake news you can see here. There are some kind of terms being used called as Barbie fever. So it's very useful for a journalist, but for someone who needs media surveillance for diseases, this can be a new fever. So that kind of things are coming. So these are the landscape challenges you can see into the Indian media. With these kind of things and challenges into diverse diseases and non-standardized journalism, how you can accelerate this media-based surveillance. And that acceleration can be done through artificial intelligence. So I am going to share a few of the learnings of one of the pilot which was being conducted and now successfully scaled up at a national level by Vadhwani AI along with Ministry of Health and Family Welfare. This was a good collaboration where we were trying to find out answers with artificial intelligence for the classic problems of HR shortage, language barriers, lag in the alert generation from something being published in a news up to a disease alert to a disease surveillance officer. How does it happen? And then the duplication and fake news. How we solve these problems? We created automated media surveillance AI tool, which inbuilt has multilingual AI translational models. We have real-time media scanning. Whenever the new media disease is published, the AI model immediately scraps it and converts it into a disease alert. And we have features of duplication removal and adding the validation for the fake news. How does exactly this happens? It's like a funnel system where a lot of news coming into the newspapers, Google alerts, websites related to health, entertainment, crime, everything is being churned off. And we find out few possible events which might be related to public health. And then there are some systems for data filtering, parsing. There are some new features called as natural language processing tools are being used to rectify all those well-interested shortlisted events. After that, there are some criteria like number of cases, severity, the seasonal variation among a disease, and all these things. There is historic data. Depending upon all these things, a disease alert is generated for a human. And the human verifies it, and then this alert goes to the district surveillance officer as an alert to be verified and to be responded quickly in terms of the outbreak investigation or in terms of update about whether it was a hoax by media or something. So here you can see clearly out of all the news into the newspapers, exact 3 alerts about rise in fever cases, stray dogs in an area, and food poisoning, 3 alerts were generated. And these are early warning signals. If action is taken on stray dogs, you can definitely prevent dog bite cases and rabies. So the impact of this thing is basically, I would like to summarize it into the 2 domains. What this AI-based tool has reduced, it has reduced the manual efforts by a person. It has reduced the time for manually scanning through the printed pages of a newspaper. It has reduced the time required for data management through a lot of files, jumping between the Google alerts in the desktop onto the newspapers, which are as a pile on the table. We have reduced the time interval between the coverage of the news by a media publishing house and the disease alert going to a surveillance officer. We have reduced the chances of missing an outbreak because of problems in these translation between the news and the disease alert. And basically this all helped the central surveillance unit a lot to reduce the workload of the shortage human resource there so that they can focus on something else. What it has increased the media sources from almost 2030 to almost 700. It has increased the language coverage from 2 initially to now more than 19 languages. It has increased the disease alerts. The coverage of geography has increased to almost very remote villages where some dailies were published in the local languages. The work efficiency has increased. The coverage of visualization and data analytics was one of the important things that with one click, the entire surveillance in media can be seen by the central surveillance unit about which of the particular disease is mentioned into the media, whether it was truly a standardized term or not. Kind of like, for example, a diarrhea in the news, after 10 days, it goes to the lab and it becomes a cholera. So that transition can happen and can be data visualized by the decision makers. I would like to conclude my presentation with few of the learnings. The most important learning through last 1.5 years I have seen through while implementing this AI tool, AI fails. AI fails initially. And why it fails? Because it is a kid. Just like a kid who is wrongly pampered can do mistakes, AI also makes mistakes. So what do we need? We need parenting guidelines. In the same manner, whenever we are trying to use AI for disease surveillance or health system resilience, we need some checklists. We need some guidebooks. For example, generative AI for surveillance can be one guidebook, or LLM for health system resilience, checklist for data privacy and disease surveillance. These kind of parenting guidelines will help us to unleash the power of AI for our own disease surveillance system as such. Second most important learning I would like to share is there is always cry about adoption of digital technology by the human resource in any country. Quick adoption is possible, but before that, we need the data literacy and sensitization of people about why behind the data. It's not only about training on the manual of how to use the software. It's about why I'm collecting that data, what will happen if the data is missed or wrong. So some workshops with the end users to sensitize about this, and the V3 of data, what we call in artificial intelligence, the volume of data, variety of data, and the velocity of data at which it is being produced. All these 3 V's should be sensitized among all the people working in the public health surveillance. Then and then only each domain of our surveillance can be ready for artificial intelligence revolution. And third and most important thing which I would like to highlight here, new technologies like artificial intelligence, blockchain, and all can be speeding up the journey towards resilience. But what is needed for this is we need to break the borders. We need to collaborate to understand the use of it, replicating the use cases of it, or contextualizing something which is successful in Singapore can be contextualized in India and can be used there. As you know, media news don't have borders. One news in New York Times can be seen in Singapore. Diseases don't have borders. Zika virus in South Africa can come in Kerala. AI models don't have borders. ChatGPT developed in the United States is now being used in a village of India. So if the news, diseases, and AI models can't have borders, why do we have? So I think to work together and collaborate for any kind of these new technologies can help us to achieve that health system resilience goal. Thank you.
You can stay here. Just have a seat. I'd like to invite the panelists to join us on the stage, and if Dr. Vijay Yeldandi would pause when he gets to the dais. Dr. Yeldandi is an infectious disease physician in Hyderabad who's worked on autoimmunity, on infectious diseases and immunization, and will bring, I think, a valuable clinical perspective to the discussion, given the value of surveillance of persons who are presenting with clinical illness. So we'll have Dr. Yeldandi speak briefly, either seated or standing as he prefers, and we'll invite everybody to join us up here.
Thank you. So, like was stated, I'm primarily a clinician and an accidental epidemiologist, because after I finished my training, my first job was as a hospital epidemiologist, building from the ground up surveillance systems. So just to put that in perspective, when I went through the Niti Aayog publication on public health surveillance in India, I said, what a beautiful concept. But then I asked myself, how much of this policy can I translate from an abstract concept into a tangible reality? Because that's my expertise. My expertise really is in implementation science. I've been working with the National AIDS Control Organization for the past 18-odd years, taking HIV policy in India from NACO's prescriptions to implementation at a district level, at a state level, and so on and so forth. And then we find that at every stage, there are challenges, and the challenges really are in the last mile. You must have so many people on the ground that must do so many things. And what we found in the National AIDS Control Organization is that the same people were being tasked again and again and again with a variety of different things. So it led to overtasking. But in time, what we found possible to do is with a lot of local engagement, particularly with motivating people, one could build a system, a good surveillance system, and NACO's Prayogshala is a good example. Over 5,500 centers of ART centers in India, laboratory testing is linked from the lowest level, ART center, to a referral center, to the national reference laboratories. And sitting at NACO, the Deputy Director General of the Laboratory Division can, with the touch of a finger, instantaneously know exactly what is happening down to a district level. So it's possible to do. So I think that with time, the application of technology, with a great deal of discipline, a lot of things are possible to do in surveillance. What is a challenge, I think, is to take that concept and apply it to a broad perception of health. So let's talk about community-based health surveillance systems or community-based event reporting systems of anything like that. Because really that's where we start looking at what is happening at a community level and asking the question, does the information that we have, the data that we have, translate into actionable knowledge at a community level that the community can use? And that's where the challenge really lies. That's where my challenge was as a hospital epidemiologist. I could show people data. I could show people how many infections there were. My first challenge was investigating an outbreak of infections post-coronary artery bypass graft surgery. And I went through everything in great detail and couldn't figure it out until I actually stood there to see what was happening to a patient right from the start, the patient being admitted, going all the way to surgery and coming out. And then I realized the problem. The problem was not with the surgeons. The problem was with the people who were preparing the skin. They were shaving the skin prior to surgery. So we had to stop that practice. But stopping that practice wasn't easy. If you can't shave, what can you do? Well, use clippers. Where are the clippers? Get clippers from the administration. Then we found that people were actually hiding blades, shaving blades, and stuff like that in the operating theaters. So changing behavior, just taking simple data and making people change behavior based on all the surveillance that you did, based on all the fact-finding that you did, is yet another challenge. So as I contemplate my own personal experiences, both at a microcosmic level, the Hospital Epidemiology Center, and then looking at implementation of national policy, trying to figure out how much HIV there is, and now we are trying to work on how much drug resistance there is to ART. That's our next challenge for the Indian National HIV Program. What we see is there are some common challenges, and the common challenges are, how do you take an entire system and use it to take information and data and change practice, change human behavior? Because that's the reality. If you want to prevent another outbreak or prevent another big problem from happening, one has to change human behavior at an individual level, at a collective level, at a government level, at a non-government level. And all of this has to be integrated together, and this is where the rubber hits the road, I think, that the last mile connectivity and how that kind of information is taken back into the community and from the community, at least in India where it's a constitutional democracy, how that community level of understanding can impact on people making policy and the decision makers deciding that they will allocate the necessary resources for making sure things are changed. So I'll stop here and I'll answer any more questions people have.
Thank you very much. Our next speaker is going to give us a bit of a laboratory perspective from his own career. Dr. Rakesh Mishra is the former director of the Center for Cellular and Molecular Biology in Hyderabad. His current position is director of the Tata Institute for Genetics and Society in Bengaluru. He is both a fellow of the Indian National Academy of Sciences and also is a member of the U.S. National Academy of Sciences. We're very pleased to have you, Dr. Mishra, and we welcome your comments.
I can speak from here. Thank you. Thank you very much, and it's very interesting, and we are learning a lot. And so, coming straight to the problems that is surveillance, which we all want to be implemented, probably everywhere in the world. Otherwise, it will make little sense. Based on what we have been doing in the country, in India for past more than 3 years, motivated by COVID, we have made lot of progress, lot of learning, but also we see the problems, I think, in this kind of audience that need to be discussed. So, first to give you a little bit of background, that we are doing a 4-city cluster surveillance, which is in Hyderabad, in Bangalore, in Pune and Delhi, supported by Rockefeller, very generous support. And so it's a relatively large study that we have been doing. And we have been using STPs, that is sewage treatment plants, and also open drainage system, because much of the country, open drainage system is the main source for surveillance. And those have their different challenges. And while for the SARS-CoV-2, you can have really very good, you just saw the data from the Singapore, very similar kinds of data is generated in many other cities. So Singapore is like city, but a place like India is very heterogeneous, and many places you have to have a really very innovative ways of sampling, and heterogeneity becomes a big problem. So from what we have learned is, although you can do the surveillance in a very reliable manner, and we also saw invisible peak, which just came down in many cities, but because are largely asymptomatic, so we don't see the cases, and testing has already come down very significantly. But it also shows that environmental surveillance does give you the real sense of what is happening in the community, in the cities. And actually, depending upon STP or the source of the water, you can even go to ward level and come with very interesting data. But if you're talking about AMR, then you have to different strategy for sampling. We are seeing very reliable way of measuring the AMR, but you don't have to do the same frequency. Maybe you can do once in a month, even is okay. But then there are other pathogens. So how often we should do metagenomics and include new pathogens, or delist some which we are continuously currently following. So those are the challenges that will keep coming. We have now, from whatever we have learned, what we are focusing is to come up with the SOPs which are applicable to small cities, large cities, open drainage, and STPs. Then we need to really indigenize and make the test kits affordable. You cannot, unless it is scalable, unless it is economically viable, it is not going to go very far. We have already forgotten almost that there was a pandemic. And although we just heard that next pandemic may come in 10 years, 100 years, I think we need to discuss more. Next pandemic might be there around sooner than that, the way we have globalized the whole world. So, so what we have to do now is to set up a system in which we are able to convince from the top, the policymakers, the politicians who take decisions, that this is very important, that there is appropriate funding available for this. But at the same time, we have to generate a workforce who can actually implement this. We cannot do so much of automation, particularly in a smaller or rural settings or small towns, where we have to have the sampling and then maybe aggregation, so that it comes in certain district level or wherever we decide, and then analysis is done there. And maybe sequencing and all can be done at even bigger laboratories. So those system has to be in place. So lots of people need to be trained. And at the same time, we have to do a lot of public advocacy, outreach to make people stay convinced that surveillance is very important and what role they can play. Because if the people are convinced, that slowly it also goes upwards, and the politicians also become convinced, and civic system then pays more attention. Otherwise, we tend to forget. So I think it's continuous. Maybe AI and these kinds of method will be very helpful. And the one more point which I'd like to bring in here, and then maybe we can have more questions and all. That how we know that we are doing enough surveillance. Is it we are overdoing in some part, or we are missing out certain things? So we have to have a little broader consideration of how we are putting this surveillance part in One Health concept. And maybe we have to develop a One Health index. Recently now discussion have started, a few hundred parameters are being built. We are doing One Health index idea for India. Very, very challenging. We just heard the data, because any index you need data, the data becomes an issue sometime. But the smart system is where data gap can also be considered and accommodated, because that's going to be the fact of life. And and then heterogeneity of the country is a big challenge. You see different states in India, they look like very different from the healthcare system and many other cultural and other aspects. So you need to have a overall, and then maybe a regional, geographically or a state-wise One Health index, and that should create not a negativity, but a positive aspect, that what few parameters if they can achieve, then the state's One Health index will go up. So we can create some kind of objective or a target for the states who might be a little bit lower in their One Health index. So we are working on such a formula, but I think this needs to be discussed more, because this is something evolving. We understand only some bit of it, and many of these things will come when we do more work and learn from each other. So like we just heard, I think the borders we have to just forget, because viruses don't have borders and ideas don't have, and we need to work together to learn and maybe reduce the pain in the future with these kinds of efforts. Thank you very much.
Excellent, thank you. Very salient comments. Now, the last speaker in our group is an old friend, Chang Liu. He is CEO of the Ask Health Asia group, based both in China and in Singapore. He himself has studied the health system of Singapore. He's looked at special issues that are challenging for the country, like care for the aged, he's been termed an ecosystem builder. And with that term, ecosystem builder, I thought he would be a suitable last speaker for our group. And he can build an ecosystem around the previous talks. So please join us.
Thank you very much, Dean Vermont. So as Prof. Vermont just mentioned, I think I grew up in China and studied in the States, in Germany, and also came to Singapore about 11 years ago. I became Singaporean about 6 years ago because the amazing work the Singapore government has been doing, I think, really is systematic. But I feel I'm a global citizen. So as a global, my background, as Prof. Vermont mentioned, is health economist. So I'm not an environmental scientist or infectious disease expert. So personally, I don't think my expertise contribute much to the topic on this panel. So I will share a little bit on the work our organization has been doing. Prof. Vermont just mentioned Ask Health Asia. So actually, we are a spin-off from Access Health International. Very closely working with Dr. Reddy and the team here. I think our positioning have been twofold. One, we really want to be a global organization that understands China. So now, because in able to do that job better, we have to spin off to be a Singapore entity from a US foundation to become that global Asian platform that understands China and bring China into the dialogue of global public health and global health systems. And second, I think because of the environment we work at, especially in Singapore and also in China, there are not so many funding from development sector. So we try to currently understand what private sector innovation has been doing and how they can potentially be aligning with the health system transformation objective. So then the second positioning we then have is the health system think tank that understand the private sector and work closely with them. So at least I think we try to be like them. We definitely don't hate them and not afraid of them. So I think those are sort of our strengths that we are trying to play in Asia, bring the China perspective and private sector perspective into the global health dialogues. But I think in able to do that, there will be a few steps to take. One is to articulate really what their work is, right? I think we heard amazing case studies on this topic from Singapore, from India, from other places, but it's sometimes difficult to hear a clear articulate of the case studies from China or from private sector, simply because language barriers come from different perspectives. After the articulation, then they will also need to have alignments of interest and cross-learning before actual cross-border collaboration can be done. So with that in objective in the last 4 years, so we work on various issues, but also starting to work more on infectious disease and also in the civilian space because of COVID. So in the January of 2020, we started our project with Rockefeller Foundation in China. Actually, that was one of the first work in China in COVID from a global audience perspective. We documented about 20 case studies on how digital technology, especially in surveillance, has been contributed positively in COVID response in China, and highlighted that and transferring those knowledge and dialogue into the global audience. And in the last 2 years, we just starting to systematically looking at the intersection between climate change and health. So we published 2 reports, one with World Economic Forum, another one with Rockefeller Foundation on climate change and health in China, specifically how to leveraging precision public health tools. So I think we systematically documented about 10 case studies in China, like some of the cases the fellow audience just shared, so speaker just shared on the various form of national or local level precision public health tools that developed in China, and hopefully to be able to bring some of those cross-learning between the borders. And we're just embarking a new project with the Hong Kong Jockey Club, looking at AI and digital health solutions in this domain, and especially also bringing some of the innovations that are happening in China or the rest of Asia, and convene that across to the global audience. So maybe just 2 quick comments before I hand back to Prof. Waman. I think one significant gap, especially coming out of the health system, but not infectious disease domain experience for my personally. One of the key gaps is certainly the linkage and integration. We talk about the international cross-regional linkage and integration. In fact, yesterday, the Chinese government just announced they are building the world's largest surveillance system. They had a big news in China. I don't know how that come out the global audience, but certainly I think a lot of systematic effort that they're doing needs very rigorous integration with the global audience. And secondly, is between the national and the local city level measures and efforts. I think Singapore has been doing great because it is a national and also city level. But I think in many other places, especially in bigger places like China or India, there are a lot of technical expertise still sit in the national level, but the local level are the ones at least taking the responses, right? So that's where we see a lot of variations and challenges in the response phase, especially in this domain. So how to be able to create more capacity and building in the local level. And lastly is the public-private sector effort. So I think a lot of the case, they were just sharing my fellow panelists talk about the surveillance model and etc. We have seen a lot of technology innovation, both in AI and also in genomic testing, that really happening in the region, driven by private sector. And many of them reduced the cost of the procedure or even sort of reforming the whole supply chain. But currently, I think that systematic work in private sector hasn't been fully integrated with or exposed to the public sector yet. So I think there are a lot of work can be done there. I'll stop here.
I wonder if I could invite Shrikant to join us. This is the Q&A that you've all been waiting for. First of all, thank you, Dr. Liu. Do we have, the microphone is over here. There might be another one somewhere. So please don't hesitate to speak up if you have a question or a comment. There's the first hand, and here's the...
Thank you. This is a question for...
No, we don't need another chair. There's a chair right here. Not necessary. He's got a chair. I'm standing here. Please, go ahead.
This is a question for either Dr. Rakesh or Dr. Wong. So, very interesting to see the wastewater surveillance as a key play for health surveillance. But I wanted to understand, where is this in general in terms of national policies and agenda? Are you seeing active adoption countries, and Dr. Rakesh specifically with respect to India? And second, both of you mentioned very urban context. I wanted to get a sense, how far in the rural context do you see this as applicable? Especially, what is the minimal size? Because in a city like Singapore, the map showed almost 500 sampling points. So I'm wondering, if we were to start taking this down to rural India, do we really do this up to a village level, or what would be the expectation?
Okay, so so I'll just very briefly. So India is having a very high-level discussions, interministerial, and in fact, there's an institute coming up in Nagpur, One Health Institute. So who is going to then probably supervise this? And there's another program, National Referral Center for Zoonotic Surveillance, which Central Zoo Authority is organizing. These are multi-ministerial, and lots of political will and support is involved. So I hope that this thing will come out as a really a practical solution to some of the things that you are mentioning. And these are on fast track. And the question is used about these are, so currently in India there is something called INSACOG, which is a kind of a collection of laboratories set up during the COVID time to do surveillance and collect data together and analyze it together. That is still continuing, and the focus of INSACOG has shifted to environmental surveillance, particularly wastewater surveillance. But these are still happening only in few cities. There are probably some 30-odd labs involved. Many of them have stopped doing because there is no COVID issue now. And so those things, that's the matter of concern, that slowly it goes down, and then financial support also starts to decrease because this is not anymore a priority. So those are the things that has to be really looked at very carefully. And the last thing, I would like to say, the surveillance at village level is the real challenge. You don't know how to collect. There is no sewage system there. So what sample you are going to collect? So maybe one has to think of new ways of sampling. That's the new strategy, whether sometimes maybe air surveillance, sometimes maybe vector surveillance, or other from the cattle or from the dogs. So there are a few things that one can think, and lots of discussions are happening this time. But this is a challenge to make it more comprehensive. Some might say it's not maybe needed to that detail of surveillance also. We have to see that we don't overdo it so much that we become useless. So we have to be careful.
Thank you. Yeah, I fully agree with the comments, and maybe also to share about like the wastewater surveillance space in a global setting. Many of the communities that have been working individually in our own countries for wastewater testing, for example, for COVID, we're now realizing the power of coming together. And in fact, in a few weeks' time, we are going to meet as a global consortium on wastewater surveillance. And there would also be another meeting in Singapore. And the whole objective is exactly what you've mentioned, which is to really activate more communities and even unsewered communities to look into maybe a wastewater surveillance system. But this would well, this is also a challenge. It is an aspiration, but also a challenge, because we agree that there would be like areas that need to be researched on. For example, where do we sample? What would be the most optimized like sampling strategy, especially for unstewarded communities? But therein also lies the strength and value, because we know that these are the communities that lack health surveillance systems as well. Yeah. I think this is really something that we could advocate for in terms of funding and research as well. And from Singapore's perspective, we believe that we know that we are a small country. We know that we are very urbanized, but we'll be happy to contribute in the area of capacity building, as well as also participating in some of these research to advance wastewater surveillance. And at a policy level, we do believe that this is important, and it's an infrastructure that should be, in a way, like maintained even in peace times. Thank you.
Yeah. So this is not a question, this is more of a comment to what you had asked. You know, now, as you know, under the AMR initiative, we had India had the National Action Plan, so that is over. Now we are going into NAP 2. So in the process, you know, as NITI, we are coordinating with all the ministries and the states to have a proper framework for both surveillance and testing. So in that, Ministry of Environment, then, you know, for the zoonotic ones, the Ministry of Animal Husbandry, Fisheries. So all are together, a concerted action plan is being worked out. And as a part of NAP, you know, the surveillance and testing, as I said, will become very important. And we are ensuring that all the available resources, for instance, FSSAI has various labs across the countries which are not used optimally as on date. So they will also be roped in for testing facilities as and when required. So that entire network is being, the ministries are doing, NCDC is the implementing agency, but NITI as the overall is sort of coordinating the efforts at the national level. So I thought I'll just mention that to give you
just one comment and also the response. Since most of the discussion was around the surveillance systems and how to integrate into the new normal surveillance systems, looking at feasibility and economic viability and contextualizing. Since the session also is meant for a response system, the alert and the response system, and given the experience of the natural disasters and the countries which have instituted the natural disaster response systems, we can see the impact of that. So are there any kind of a policy directions in terms of having a similar public health emergency response systems, a coordinated public health emergency response systems? Because alert is one, but unless alert is acted upon, there is no meaning in that. Second, too much alert can also cause chaos. So unless there is a coordination in terms of the response to a specific alert. So I would like to have the comments from the panelists on this component of the session.
Let me take a stab at that. We do have biostatistical strategies to help rationalize surveillance data. I'm thinking of aberration detection tools like Farrington, which is one of the biostatistical strategies to identify when you have an alert, when you have an alarm bell going off. There are generalized linear regression models where you can take somewhat chaotic, underreported data, but whose trends may actually be relatively valid. But the absolute numbers are somewhat chaotic, and one can use these tools to help identify. Now, I'm not saying that fancy biostatistics is the solution to what you're saying, but I'm saying it can help take out a little bit of a human factor when persons who should be acting aren't acting, and to to make that bridge between discovery and action. Sometimes, especially in high-income countries, it's easy. The state of Connecticut in the northeast of the United States, near New York City, does seasonal mosquito surveillance. We capture mosquitoes by the hundreds of thousands. I think it gets to the millions sometimes. And we grind them up and we test for Eastern equine encephalitis virus, and we test for West Nile virus and 2 or 3 others. And Judith is smiling because they do similar things here. And our action is we grind them all up, but only from a discrete geographic area. And then if we get a signal, that's when the 3 a.m. spray teams are going in to do mosquito knockdown, because we're trying to avoid even one case of West Nile or Eastern equine. Now that is an expensive, high maintenance system, but it's a simple marker. If there is a positive mosquito batch, we act. And I would say the complexities for this kind of system in China or India is not as straightforward, nor is the ability to survey in this way. But when you think about all the different surveillance systems that we've alluded to this morning, you're absolutely right. There's a tremendous challenge. The valley of death of information transfer and action is a conspicuous problem, because think about it. We have heard about environmental surveillance, and wastewater is one of several examples. We've heard about biological surveillance, as in the case of the mosquito, surveillance that I was mentioning. We've heard about medical surveillance in two ways. One is the reporting of laboratory and clinical data to a centralized source, like the NACO, and the whole concept of hospital epidemiology and healthcare epidemiology, which is all about improving systems to reduce risk. We heard about popular media surveillance, and if I could add to that, health surveillance. So my cell phone has multiple times the power of the computing of the entire Houston space system that sent men to the moon. This cell phone has multiple times the power of that entire computer system. And we can track where all of us are going, and we can map it. So there's a lot, when you're talking about mobility, and you're talking about evaluating systems, the mHealth goes even beyond the popular media as a tool for surveillance. If you're talking about a COVID lockdown, how do you measure whether people are adhering? Well, this is how we measured it, and there are a number of papers on this. Then you have the animal surveillance, the One Health concepts that you highlighted just when you started our session this morning, Dr. Reddy, and we even heard a little bit about economic and healthcare surveillance. You could add civil stress, as we heard this morning, the notion of surveillance of events that can reasonably be estimated to have downstream adverse surveillance effects. If you've got a circumstance like Ukraine or Gaza, you don't necessarily need all the other evidence to know that you're up against it when it comes to health. I'm sorry, I overdid my response. I think I'll shut up here, but it is absolutely right that this is an intense challenge, that the surveillance efforts that we make get translated into action, and that action has a justification. So you can't have a surveillance officer here saying we have to do action, and the person who's supposed to do the action says, I'm not going to do it. There has to be some degree of criteria whereby those decisions are made so that it's not optional. Because if it's optional, you're going to have aggressive people on one end acting and not aggressive people on the not acting, and that's not what a system is. Please.
So if I can just add to, in response to Dr. Reddy's question, one thing where I imagine we'll start getting the benefits of surveillance in a impactful ways with the AMR. If we are monitoring, because it's not a big exercise also, if say, imagine we are monitoring the city STPs and hospital STPs, and we know the dynamics of what kind of, we already know now how many pathogens and how many resistant signatures they are having. So first of all, the hospital will immediately know that how many kinds of AMRs there, what antibiotic they should not even try because this is already there, and the ones that are not showing up there, that's what they will be using. So their antibiotic usage can have this input. They have very nice system of how they decide, but this can be a good one to add. And the second thing will be from other STPs and comparing hospital STPs, we will be able to tell how many pathogens are resistance are evolving in the hospital settings and how many are evolving because of the poultries or cattle or other kinds of misuse of antibiotics and so on. And we can then take a strategic or policy decisions based on that. And I think we are not very far from those. Unlike SARS-CoV-2, what we see, they're reasonably stable. All through the year, we see same kinds of thing in different STPs. So that can become very easy way of making some actionable recommendations in the clinical setting and also at the policy level for the general settings.
Good, thank you. Now, I've already made my closing remarks, so we're going to get the last questions. There's one here, one here. So the last two comments, and then we'll break.
Okay. Very quick one about the media surveillance. I was wondering, with all the kind of heterogeneity we talk about in India, there is a lot of heterogeneity even in media reporting, especially if you look at the mainstream media and the vernacular media, the way it is reported. How do you control for it? And if Dr. Vijay will remember, during the HIV time, there were special efforts made to train and to engage with the media how HIV reporting needs to be done, because a lot of stigma, discrimination, we traced to the way it was sensationalized and so on. So since we are beginning with AI now, and we have seen it's not really, it's faltering at many times, and there are various and very serious issues, emerging out of it. So this is an early phase. I would like to know from you what you are doing at the other end of the media. How are you engaging with the media so that the alerts that you get from there are, more based on authentic reporting, not to sensationalize, but to really report cases as they are. So what we need, what we call as responsible media reporting. There is a huge difference, and I think we should take that into account when we are talking about media surveillance.
Thank you, ma'am. So as compared to this particular solution which we have deployed in National Center for Disease Control, more and more efforts are into fine-tuning the tool so that, because of not being controlled media thing, more and more efforts are taking to fine-tune the model so that whatever happens into the media, the model gets corrected in itself rather than making media to be controlled. There are some recommendations given to NCDC about conducting a one-day workshop for the responsible journalism for infectious diseases, so that sensational news are not made with the some kind of disease names which are used synonymously by the journalist. So some recommendations are there given, but as far as an agency which is providing technical support to NCDC as a Vadhwani AI, we have not yet thought of that way to like AI agency can control the models. The decisions to control a fourth pillar of the democracy are something which needs to be at higher level.
It's not to control, it's to, sort of bring
in terms of control, I'm saying standardizing it. Yeah.
Well, another thing we should mention is machine learning elements within the AI process. So if it comes back with 400 hits on Barbie fever, then you can actually instruct it to say Barbie fever has nothing to do with, maybe I should ask Judith about Taylor Swift fever last week here in Singapore. So there is a machine learning component, so the AI can learn over time and can become better and better and more sophisticated, which is helping with the human moderation, because the more human moderation you have, the more labor you need. So you need that machine learning element. Did I say that about right?
Yes.
Okay, good. Please.
My question is to any of the panelists. We've talked of surveillance. I would imagine it's a fairly expensive activity. It's also a public health good, which means it is the government's responsibility. From your experience, do you find if there is any country that has deprioritized surveillance and other public health activities to focus more on curative health, just given that the pot of money is always limited, right? So there's always a balance to be struck. Or from your experience, the countries that you've looked at have ensured that the extent of financing that is required for surveillance and other such activities is actually allocated by the governments.
If I may, very quickly, I think at least most of the countries, they're claiming that they are improving the resources needed. But just take China as example, I think but as Prof. Vermont mentioned, there are many kind of mechanisms you can do. So I think maybe they feel they're doing enough, but they're not having done the most cost-effective or most comprehensive measures. So just one quick comment on one of the earlier point Dr. Reddy mentioned as well, I think aligned with this. So I'm really happy to at least see a trend of the integration of the surveillance measurements as well. So, because we're partnering with Rockefeller Foundation, they're globally doing the wastewater surveillance, but now with the funding and coming from like Jockey Club and others, they're trying to integrating other surveillance mechanism into a more holistic observatory idea rather than just one domain. So I think if on the surveillance side, to be able to more integrate it into a formal manner, I think then we're having some common grounds we're talking to when we are talking about surveillance in general.
I think this also gets back to Dr. Mishra's point that how do we know how much surveillance to do? And there has been a lot of attention to sentinel surveillance. So the CDC in the US, which has more resources than most public health agencies, still is very selective on its surveillance strategies. They have an emergency room surveillance system, but it's only a sample frame of selected emergency rooms in representative parts of the country. They have a doctor's office surveillance system where the doctors are actually paid to report more comprehensively than doctors tend to report for febrile syndromes and other diagnosed infectious diseases, but it's only a spot sampling. So they get their surveillance data in a far more cost-efficient way. I think I'll leave the last word. Well, we have two. Okay, from now on, it's not my fault that we're late. Go ahead.
I mean, just this comment with reference to the financing question. I think the financing session is likely to address that aspect of how do the countries which have limited space do prioritize between the different requirements. The pandemic fund, I think the WHO has been engaged with in terms of strengthening both international health regulation and the pandemic fund. We are yet to see its real impact on the countries by the time actually it starts flowing into the countries and the countries actually deploy it. So I presume that there is going to be an interesting discussion in terms of how do countries mobilize domestic funds without waiting for the international assistance and use them efficiently in prioritizing these things. And the second question, I mean, which I alluded to was in terms of the requirement to have a public health emergency response force, akin to the National Disaster Response Force. It was proved to be highly effective, a national response, especially in a complex federated system. It happens in India. I mean, this was post-cyclone effects, and now the deaths that you see with the cyclones is almost nil because of the efficient response system. And there is a dedicated force for that. And the countries require that, actually, so that there is a better coordination. Just like as you alluded to, you cannot leave it to the motivation level or choice of the responder, whether I should respond or I should not respond. It's like a border. Whether the military responds or not is not a choice. They have to respond.
Good. And the final question right behind. Go ahead. Yes, please. He's got the mic. Just grab it from him. Thanks.
Yeah, this is more of a comment to Dr. Satish, and then also what you mentioned about the CDC and, of course, Dr. Reddy. I have been to Taiwan, and then where I have seen the Central Epidemic Command Center. They have a very impressive setup where the news monitoring, the media monitoring also happens. But I have seen, I think, there are about 32 plus because I counted the monitors. And then there were 2 people sitting all the time just to go through the news channels and monitoring. I know they were working on draft AI guidelines on generative AI and employing AI into pulmonary, the imaging. But I'm not very sure whether they did for the news also. But they have a very impressive setup to monitor such. And then including, they can even have a watch of those passengers who are coming in the airport to look for symptoms. So this was impressive. And then the second comment that I have is, I've been an implementer of hospital information systems. And then we had a particular field in our hospital information system where there is a notifiable diseases that you can actually mark it, and then that goes, but it was just a field. Just wanted to share that. But there were provisions. I'm talking about almost 10 years back. I'm talking about India. Thank you.
I'm glad you mentioned electronic medical records, because as these become more and more prominent within health systems, they are a marvelous source of data for surveillance in a way that paper records are less accessible. So I'm glad you mentioned that. And Shrikant, I'll give you the final word. When do you expect your very important, I don't know if it's a systematic review or a scoping review, to be completed with your team?
Yeah, thanks for asking this question. But we are almost ready. We have finalized the manuscript. We are submitting it. So maybe.
Oh, it's almost done. Great.
Journal will take.
Wonderful.
We'll get to that much time only we need.
So we'll look forward to in the near future. Well, happy to thank the extraordinary speakers. Yes, please.
Request, I think, just to fare with the online audience as well.
Yes.
Maybe if we can take at least 1 or 2 questions from them as well.
Yes, happy to. It's I see for Dr. Wong, very nice work. Is it possible to correlate wastewater data with the caseload for Zika virus, considering its mode of shedding?
Yeah, thanks very much for the question. I think logically that could be possible, but in Singapore, because our caseload is very low, it'd be very hard to calibrate at this juncture.
Yeah. I can answer for COVID. There were semi-quantitative strategies for assessing the signal strength in wastewater, which did in fact correlate with clinical caseload. It actually correlated a little bit ahead of caseload. So it predicted caseload, which is very valuable, of course, a warning system for our hospitals and our clinicians. But that was at the time of a COVID peak. And I think you're absolutely right in your answer that the rarer the agent, the less likely you'd be able to do that.
Yeah. So in fact, for Singapore, we did have a very good correlation between cases and signals for SARS-CoV-2. And in different communities, like some of them, the wastewater signal would lead the caseload.
Yes.
And so I think in terms of calibration, it does matter whether or not we are, for example, like endemic, or whether we are in a place where we're really just looking for signals. But regardless, the wastewater signals do provide early warning and alert. Yeah.
Good. All right. Happy to declare the session closed and thank our speakers.